much. All right. Well, it's great to be back home, and I'm proud to be blue. I graduated my BSN and MSN from LCU. Sat right here where you guys were, in pretty much the same conditions. We were growing quickly. So got out and started. Found a home in something that I never thought I would ever be involved in, and that was HIV services for the Pan West area. So 4 hubs I operate out of, and that's Amarillo, Midland, Lubbock, Midland, Odessa, Amarillo, and El Paso. Those are the hubs that we operate out of to oversee that 63 county area. Okay. So presenting a topic today that I hate that there's a need for, but it's something that's I've seen as a trend coming up. Something that I've noticed over the past 2 years I've been doing this. So we hate to be here to do this, but we need to. It's something that needs to be done. So let me get this guy all set here. And I cannot get this clicker to work, so. I think I'm stuck doing it manually. Okay, so what I'm going to talk about today is HIV in adolescents. It's a growing trend that we've noticed state, national level. We're going to look at some CDC slides that I presented last year. Talk about some of the youth language and social media things that affect youth in a risk category. Some youth risk behaviors, youth law and interaction study. That's a pretty interesting study showing about how the encounters with the law play into the risks and things associated with contracting HIV. There's a seat back here.
Okay.
Oh, you sure? Okay. All right. Man. Okay, and then we're going to talk about some possible solutions and then kind of where we go from here. So the problem that I identified were Texas adolescents and young adults, also nationally, not just in Texas, but we're contracting HIV, and it continues to increase while other age categories kind of stay the same. So what that is we've broken this down into 13 to 19-year-olds, 19 to 20 to 25-year-olds. The 20 to 25-year-old continues to be the highest category. Hey, yeah, come on in. Come on. Hey, no problem. Come on in. Yeah, you'll have to get a tardy slip. So the other age groups will remain relatively stable. So up to about 55. And then the other interesting thing that I saw is 55 and over has had a big jump. And anyone care to figure out why that is or give your insight? Viagra. It works. Yeah. So that's a growing trend as well. So talking specifically about 13 to 19-year-olds, we revisit this a little bit. Talk about the population in the U.S. 13 to 19 accounts for about 23 million, give or take. And this is out of 40 states that reported, though. So we're talking about we're missing California, the whole West Coast. But 40 states that put in on this survey. So the diagnosis of HIV infection numbered about 2,000 roughly in that age group, and you can see where the biggest. Oh yeah, thanks, great. That works good. Is that better?
Yeah, that's better.
Okay. So you see here the biggest account for that is 73% is African American. Now the trouble with that is that this is 73% of a relatively small group, but makes up such a large disparity, you know, and that's what was troubling to us. So as I started looking into this, I noticed that there's quite a bit more outreach, there's quite a bit more testing, there's quite a bit more community involvement in this racial ethnic group. So that may be part of why some of these numbers are so high in that category, but they're staggering high, like 6 times higher than white or Hispanic. Then talking about between males and females, 13 to 24 years old, so this will be a bigger number because it's a larger group again, okay? So then here you see again African American versus Latino and white. Yeah, come on in, man. And then again, you know, like multiple races, Asian, you know, make up 1% or whatever. But this this category here is really a, you know, troubling number. So to kind of put this in context, come on in if there's a seat. Okay. So so if you kind of just put this together and look at the U.S. As a whole here, again, like these states didn't report, some of these other white states didn't report, but Texas typically in this age group, just 13 to 19 out of these 40 states, our HIV contraction rate is about 9.9 per every 100,000 people. So I'll show you in a minute what that equates to in Lubbock and what the rate is. But you see here, like Florida, Mississippi, some of the southern states, really high. I would venture to say that that would probably be the case out here too. They just, for whatever reason, didn't get in. So on average, it's about 8.7 per 100,000 in this group here. Now up to 2009, that accounted for about 12.9, right at 13% of the total HIV contractions in this category. Now up till 2011, that had jumped up to about 21%. So that's where I started really, you know, zooming in on these guys to see what was going on here. So then you look at 13 to 19-year-olds, 20 to 24, and greater than 25. And of course, this is a group that was a big focus for a long time, and we've seen these numbers actually fall in this age group. Still stay pretty much the same in this age group, growing, but in this age group is really, like I say, doubled almost. So here's the 2010 death rate and amongst blacks, white, and different age categories here, broken out pretty large scale though. So it'd be interesting to see what those are in the smaller groups. But you can see how this is all tapering off here, and the reason for that is that we have really good drugs now, you know. And typically now you contract HIV, you take your meds, you do the right things, you eat right, your genetics will be what kill you, you see. But one of the other things that we've noticed is as you're taking these meds is long bone fractures, weakening of the bones. So that's become something that a young guy will come in with a long bone fracture, pelvic fracture or something like that, and then they die from complications. So, and it was something that I've noticed just over the last year when we did our audit out of Midland, Odessa, we had like 7 deaths. And I was like, man, what was the contributing factors? When I went through looking at the audits, there were about, every one of them was in a traumatic injury or something and broke a long bone. So we went to a conference down in Corpus Christi, and one of the leading experts talked about specifically the osteoporosis involved with long-term use of some of these drugs. So there's a lot of things that are happening now that we're finding out because we've got a lot of data to analyze. So just something to keep in mind. This is a busy slide, but really this is a part that we want to zoom in on right here, and this is where I got my my information. And this is kind of cut off here, I'm sorry about that, but this is 21.7, I think, right out here, and 13 to 24 age group. So you see these numbers here going across relatively the same, you know. I don't see a whole big jump there. Actually some trending down in some of them. Again, 55 plus. And then right in here, you know, you see these numbers, 667, 739, 858, 957, count for, you know, 21.5% right there. So, you know, that's something that I noticed right away. And so then what I wanted to do was kind of get a whole concept of like why, you know, these disparaging numbers for African American community and some of the things that go along with being a provider in HIV. So I looked at this survey, and this is a profile of a provider, a person who gives care to an HIV positive person. Okay, and that's any age category. Okay, so you see here about 83% non-Hispanic, 68% white, Female, 58%. MD, DO, 50 to 59 years old, lives in an urban community, family practice somewhere in the South, and setting is a healthcare center. So now think back about those states that were right along here, you know, and this profile for the provider being a white female, and then think about like such a high population, African American. Do you think that they're going to go seek treatment? Okay, yeah. So that's a big fallout there too. So something that we, you know, like I said, as a whole, I wanted to understand what's going on here. Why are we having this huge disparity, and what's the all-around cause? So then, based on the provider statement, what the providers say, stigma, 52%, English proficiency, 28%, and all these others kind of fall into it. Access of care, for sure. I would venture to say that's probably a little higher. Otherwise, you also look at concentration. Like if you have African Americans living in one area of a city versus you know, all of the care providers being in a certain area of the city, do you think they're going to travel over to seek care? Probably not. So you know, some of the things to think about for their causative. Everyone associated with stigma. Everyone understand what stigma is? Okay. If not, we'll have a question and answer section here. So then also I wanted to understand, you know, understand more about adolescents. Well, they speak a different language. So when you go into nursing, you have to learn medicine, you know, right? You have to learn the language, learn the medical terminology. Well, same thing with adolescents. I remember growing up, we had our own little language, you know, that we spoke in class to keep the teachers off our back. And, you know, this is like laugh my butt off. Do I look like I give a parent in room, mom in room? You know, punctuation in caps mean emotional emphasis, mad, sad, yelling, those kinds of things. These little guys here, you know what those are? You know what those are? Now they're emoticons before emoticons came out. So, you know, this is like dazed and confused. This is like you kill me. This is like I'm not impressed and happy. Right? So everybody speak adolescent now? Okay. So also I looked at social media, and social media seems to be one of the most powerful tools for adolescents and teens right now. The teens use text and social media to interact, so much so that they have lost human interaction in some accounts. Like what they do is they expect for their teen friend or adolescent friend to be available 24/7. Get the phone, pick it up off your chest if you're dead asleep, and text back, right? So it's an instant relationship, but it's also one that could be dangerous too, because also, I mean, you don't know who's on the other side of that, especially with Facebook and all these other things. So I looked further into some of the social media websites, and there was a lot of e-bullying, a lot of e-hookup kind of things where they put out there like, you know, hey, tag me, I'm hot, or something like that, or whatever, or like me if I'm hot, or, you know, those kinds of things. And then bullies, you know, coming in and saying like, you know, you're disgusting and things like, you know, just stuff like that. So online predators as well, looking for the opportunity for, you know, like I have a Medline article right here about 30% of U.S. teen girls meet up with online strangers, and talks about how sexual abuse and molestation and assault in the home plays a big role in that. So tattoo solicitation in parties. Anybody know who Mike Diaz is? Any of you guys? Young guy? No? He's a guy that's soliciting for tattoos on the hour. Like he'll go on Facebook and say, I've got, you know, I've got an hour open, I've got this, I've got that. And what he does is you come over to his basement, he puts a tattoo on you. He does really good work. But I mean, hey, I don't know what his sterilization process is or any of that. And I just gave a hepatitis C seminar not too long ago. Hepatitis B too. So also so powerful they can take a life. I've seen a lot of photos on there depicting death in some way or another in teens. And the way that I did this was I became a 16-year-old boy and I went online and made a Facebook profile. Okay, it's also how I keep up with my teen daughters. I was in the military. All right, so increased risk behaviors. With juvenile justice encounters, the more times this study that I'm about to show you talks about the more times that you interact with the law, the more likely you are to engage in risky behaviors that could cause you to have the potential to contract HIV or STDs. So sexual risk behaviors increase, and you're more likely to participate in other criminal events. And self-mutilation, that's cutting and branding, those kinds of things. Or one of the things I saw was snipping the tongue. That's a new thing now. Snipping the tongue to make it be fork-like. You know. So the study here was Northwestern University. As a longitudinal study, Chicago Cooks County Juvenile Justice Center. They took 689 boys aged 10 to 18, high rates of risky sexual behaviors, increased risk of HIV and other sexually transmitted infections. And now what they did was, this is self-report. These students kids took a survey, and they talked about 3 months prior to their law encounter, how many had unprotected sex, how many had sex while drunk or high. So you see those numbers are fairly significant. Then they studied them on a longitudinal basis, so they went 3 years out and followed them. And this is what they found. 50% increase in prevalence of risky sexual behaviors. Okay? Then use of drugs or alcohol increased. Highest increase when sex was in conjunction with drugs and alcohol. 75% engaged in 5 or more risky sexual behaviors. And then more studies are underway. Houston's conducting a study like this right now. So it'd be interesting to see here in Texas what that pans out to. I think Dallas is looking at this as well. Great study. So then alcohol and other drug use. So 24% of these guys drank alcohol or used drugs before their last sexual intercourse. 3% used a needle to inject illegal drug into their body. And then this new designer drug market, like the bath salt, spice, the legal marijuana, those kinds of things. We've not even begun to understand what those things will do yet. So we're still, it'll be a long time before we know what long-term effects we'll have from using that stuff. But like your salvia and all those things like that. Okay, so you guys stay away from that.
Can you tell us what a risky sexual behavior is? Like, is there sexual behavior and then there's risky sexual? Is that different?
Well, risky is where you're not using protection. Or you're just getting drunk and then, in conjunction with sexual behavior. So, I mean, risk is defined in a lot of ways. Legal and medical would show, there's two different terms. So, insurance companies would define risk a different way. Like they always want to assign fault. Who's at fault here or what. So those are. Does that answer your question? Does that help?
I was just wondering, so you said sexual behavior and risky.
Yeah.
I didn't know if it was.
Well, here's my take on that. I'm a soldier, and when I go out into the battlefield, I make sure I got all my gear on, and that's everything that's going to protect me, right? When you go out to the club and you're talking to that guy or that girl, I hope you've got the protection that you need when you go out into the battlefield. That make sense? Okay, you take it how you want. Okay, so what's the problem in Texas here? The sexual risk behavior, so 52% are having sexual intercourse. Now we're talking about teens, 13 to 19, right? Okay. And then 7% had sexual intercourse before the age of 13 years, okay? Then 17% had sexual intercourse with 4 or more persons during their lifetime. They're still in that group, and if this may be actually up to 24, but the majority of these are from 13 to 19. Okay? Now, this is for Lubbock. Cochran, Crosby, Hockley, Lynn counties. These are the 5 counties served by our prevention guys. And Freddie G's back there. He can talk to you guys a little bit if y'all have some questions. So this is what, in the 5-county area, we have about 7.4 per 100,000 population in Lubbock of syphilis. We'd all but thought that syphilis had gone away. We thought that we'd gotten rid of that, but it's out there. Gonorrhea, 180.5 per 100,000. Chlamydia, 624 per 100,000. I think this translates into something like 13,000 cases or something like that. And then what we were looking at is state and national. Texas, we're number 1. We're number 3 or number 4 in that group. And that's behind Dallas, Houston, and other big cities, right? And that wake up call, right? That's big. So yeah, nationally, 101, 116, 6.6, 4.5. You know, way down in the national level. So AIDS, 8.5, and this is talking about when HIV has become AIDS, the autoimmune deficiency syndrome. So they're two different things. Is everyone clear on that? Okay. HIV is a virus when you contract it. Okay, you seroconvert and you're HIV positive, and then if it destroys your CD4 cells and you cannot fight off infection to where your CD4 has become less than 200, you're in AIDS. You're considered to have AIDS. Okay. All right. So specifically to Lubbock, there's 602 HIV cases, which is about 111.3 cases per 100,000. And this is a Texas HIV surveillance report. Also, I have access to a database called ARES, which you'll never be able to find. It's encrypted. There's no way to access it unless the state gives you a certificate. And it is the repository for anyone who's receiving Ron White HIV services. Okay. So, looking at some notable risks for racial ethnic groups, looking at the largest ones in those pie circles.
Is this just for Lubbock or is this for Texas?
This would be for Texas. Yeah, I'm sorry, I apologize, but yeah, I'm kind of shifting back and forth. But I wanted to show Lubbock's area. Yeah. So overall, Hispanic high school students who are polled and there'll be a video at the end of this that talks about the 12 Cities initiative, and Dallas and Houston are in that, and this is where this data is coming from, okay, out of Texas. So Hispanic high school students were most likely to ride with a driver who had been drinking alcohol, felt sad or hopeless, first drink of alcohol before 13, ever used cocaine or inhalants or ecstasy, did not use any method to prevent pregnancy during last sexual intercourse. White high school students most likely to have texted or emailed while driving, been bullied in school property, electronically bullied, used tobacco, smoked cigarettes daily, indoor tanning. I don't know why that was. I guess the tan moms ruined it for everybody. Yeah, so I actually reflect race, so you know it doesn't do me any good when I. So yeah, so. Black high school students were most likely to have been exposed to alcohol in some fashion, whether in the home or in social engagements or something like that. Have engaged in risky sexual behaviors or ever had sexual intercourse or had intercourse before the age of 13. So this talks about the percentage of high school students who were tested for HIV by sex, race, and ethnicity up to 2011. So the total was 12.9, you know, out of this age group category, right? So again, you see like the black population 24.0, and you know it's double what the other two are. But again, like I said, you know a lot of this may be caused from several factors: more outreach, more intervention, more studies, more testing in that community. And then what was most likely to happen with white or Hispanic was that they would go into the doctor with some chronic illness, cough, something or other, and then that's what shows up when they finally do an HIV test. But this is just breaking this down for race and ethnicity for that particular group, and this is all we tested for that age, that range between 2005 and 2011. It stayed about the same. So only about 11%, you know, 12% of high school students are ever tested. So there's another fallout. So talking about health education and what's the status there, because everyone talks about education. You know, education is the key, this and that, whatever. Well, yeah, the type may be, but you can see here these numbers are relatively high. for being taught or access to reliable health information, lead health education teacher who received professional development, taught 8 key pregnancy, HIV, and other STD topics in a required course. I don't know what those 8 key pregnancy things are, but these numbers are relatively high in what's being offered, except for the one where they're required to take 2 or more health education courses. But 80% had a full-time registered nurse, but I don't know what the degree or what their experience has been with HIV or STDs, or what level of involvement they're able to give at the high school level. So that also is a factor. And if they've even been trained in that environment, that realm at all. And then family involvement, 37% of providers and parents' families had health information to increase parents and family knowledge of HIV prevention or teen pregnancy prevention. So 32% had a gay, straight, or alliance or similar club. 7% provided curricula or supplementary materials and engaged in 5 practice related to lesbian, gay, bisexual, transgender, or questioning. Questioning means that that's a student questioning whether or not they are one of these others. Or gender dissociation. I don't know what I like, but I know that it's, maybe I like both. Maybe I like one or the other. So, possible solutions, definitely family involvement. Family involvement has been shown to be one of the highest initiatives in having support for the family member, the student, the child. Education, not just education, but assessment and intervention. Like what level of education needs to be given here, and how do we get it there? And I can't go traipsing into the high schools around here and say, you wear a condom and do all these things, because they just don't allow it. So the specific types of education, key to intervention between HIV, contracting HIV, that's probably one of the key things. Supportive policies. This is at the national level and state level with testing initiatives and things of that nature. We've had a lot of support in testing what is it, the quick oral quick, yeah. That's a great tool for these guys that are out in the field. And then more targeted comprehensive health services, and that's part of like the national strategy, the state strategy for HIV, to target groups like the African American population. And one of the things in that is that kids who have had male to male sexual contact, and let me define this a little bit. So an MSM is a man who has sex with men, but does not identify himself as gay, but will have sex with a female as well. And so that plays a lot into the population disparity as well in the African American community, because there's a high concentration, and there's a high concentration of female population as well. Okay, so that's a factor that shows to be a factor. So also removing stigma and bias. Being able to remove that stigma from going to the doctor or seeking treatment, or like one of the providers, for instance, in another area of Texas, has this huge van out in front of it that says HIV testing and stuff like that. Now, nobody wants to be seen walking out of there. Yeah, so that's true. So. Yeah, everyone's tucking and rolling out the back door. So. And bias, bias from providers, people who are the deliverers of care. It needs to be an open forum. It needs to be a lot more discussion, a lot more insight into where these people are coming from and what disparities they have, and also the factors that surround their care. I mean, can they not get there because of transportation? Can they not get there because of they have a kid, or what are the factors that are involved in that? And so the folks that we deal with as Ron White providers, they do a great job of finding all this information out on intakes. So I list here the morbidity and mortality world report, and this is also now the weekly report that comes out in a journal form. This is where I got a lot of this information, and this particular one here was is really instrumental because it talks about how many times white kids drink soda, Hispanic kids drink soda. It talks about anything and everything of adolescent behavior. So it was a really good tool for putting this together. So then more effective school health programs are needed for definite. I mean, we see that these numbers are really high, but what is the focus of the education and the delivery method? And one of the things that you learn here in this program is like you've got to teach to your audience, you've got to be able to understand why someone's not comprehending and then be able to adjust your teaching methods. So that may be an effective intervention. Then policy and programmatic interventions that are needed to reduce risk and health outcomes among youth. So at the national and the state level, policies that really are open and accepting to HIV forums, to coming in and speaking at the teen level, at the high school level, and making this available to youth. And then of course, the parents for sure being involved and talking to your kids, your kids talking to each other, yes.
Was any of this, was there research done to look at the kids and see if they came from single family parent homes, or if, is that one of the breakdowns right there?
In the MMWR, there's a lot of statistical data that speaks to different socioeconomic and racial ethnic disparities, but there's not a study specifically geared towards that I know of.
Okay.
I couldn't say. Maybe Dr. Bonner can speak to it. Then additional research. Okay, so here's where we go from here. Additional research is needed to evaluate the effect of specific educational, socioeconomic, cultural, racial, ethnic factors on the prevalence of health risk behaviors amongst adolescents. So I'll leave you this video here, and then we'll talk with Dr. Bonner. Maybe we won't.
While you're doing that, when we go in and teach the family and the kids and all of this, that it looks like, are you going in straight on and teaching about like safe sex and don't do this? Are you teaching about self-confidence and, that way, that where the child can respect themselves and, just teach them different type of, because evidently whatever we're doing now is not working.
Yeah, those are excellent points. Those are why I'm here, to collect that type of information and take back to the national and the state level and say, these are ideas that we've come up with, because there are groups there are groups that are being focused on men who have sex with men, African American men who have sex with men being the number one, and then the different communities that are affected. So this is talks. These are things that we're opening up. The reason I'm presenting this is I did a systematic review of all this literature. Didn't find much. There's a lot of studies in Africa. There's a lot of studies in Europe, but there's not a whole lot in the U.S. So, just looking towards the future. I mean, these are all talks and forums that we're putting together to come up with better strategies. And here, what we'll hear about is the national strategy for HIV. Okay.
This World AIDS Day, federal officials sat down to discuss the progress that's been made implementing the National HIV/AIDS Strategy, as well as prospects for 2013 as we move towards an AIDS-free generation.
Hello, I'm Dr. Howard Koh, the Assistant Secretary for Health at the U.S. Department of Health and Human Services. I'm here to discuss our progress in implementing the National HIV/AIDS Strategy with my colleague, Dr. Ron Baldessari, the Deputy Assistant Secretary for Health, Infectious Diseases, and the Director of the Office of HIV, AIDS, and Infectious Disease Policy. Thank you, Dr. Baldessari, for being here today.
My pleasure, Dr. Koh.
So, Dr. Baldessari, going into 2013, what do you believe the U.S. HIV community needs to know about the progress that we need to make in implementing the HIV strategy?
Good question, Howard. The first thing I would say is the community needs to understand that the department of Health and Human Services remains committed to implementing the National HIV/AIDS strategy and achieving its goals. And we have had some substantial achievements in that regard. But we need to make sure that everyone understands that all of us as a nation have to come together and work together in order to be able to achieve the goals of the strategy. When we consider, Howard, that, and I know you know this number very well, that only 25% of the 1.1 million people in the United States who are infected with HIV have optimal treatment to where the viral load is undetectable, we know we have a ways to go. So we have challenges in front of us, but we do have the tools at hand, and this is an achievable strategy.
And Ron, what would you say are the major strategy-related achievements in 2012?
Well, I'd like to begin by pointing toward the International AIDS meeting that took place here in Washington, D.C. this past summer, which really provided an opportunity, Howard, for you and other leaders in the department to showcase the progress that we've made in implementing the strategy. I would also point toward the work that's been underway for over 24 months that has led to the identification for the first time ever of 7 core program measures that are going to be used across HHS that will enable us to look across all of our programs for HIV and evaluate how well they're performing. That's been a major accomplishment. We've also learned a great deal about what it takes to improve coordination and collaboration at the local level through our 12 cities evaluation project, and individuals who want to learn more about that can go to AIDS.gov and read the full report about that. And finally, I know that you and the Secretary and everyone in the department is very excited about the promise of expanding through the Affordable Care Act Medicaid so that we can reach many, many more people with HIV and offer life-saving care and services to them.
And finally, Dr. Valdesari, you recently published a commentary in the journal Public Health Reports on the U.S. goal of creating an AIDS-free generation. Tell us what we need to do to achieve that goal.
Well, the focus of that commentary really talked about how we have to pay attention to implementation. And by that I mean, all of us have heard the expression of achieving an AIDS-free generation, and we know that's possible. But that's only going to be possible if we attend to the very important implementation details. For instance, we have to pay particular attention to what are the social and structural determinants that are influencing individuals to seek out health care and to stay in health care. That's a very important dimension of it. We need to continue to work with communities of people living with HIV to understand their needs and preferences. And we have to mobilize and work across sectors. HIV/AIDS cannot be an issue that's only important to us physicians or to public health workers. It really has to be something that everyone in America embraces and comes together and works toward achieving an AIDS-free generation.
Great. Well, thank you so much for your leadership, Ron, and it's so great to work with you and talk with you today.
For more information on the National HIV/AIDS Strategy and for HIV and AIDS, visit AIDS.gov.
Alright, so let me just get right back in here and we are almost done. In conclusion, we talked about the problem, revisited some CDC slides, youth language, risk behaviors, youth law interaction study. We talked about the national and local considerations, possible solutions, and where we go from here. And I have a vested interest because that's my family, minus my wife. She was taking the photo.
I have a question.
Yes.
So, of course, the government is looking at providing health care for those that already have HIV and AIDS. And, but proactively, you had a slide on educating, I guess it would be junior high and high school for that age range, 13 to 19.
Yes.
And they have, what, 2 or less health classes required? to provide that information. Was that for Texas, or was that for?
Yeah, we're talking about
nation,
we're talking about like in that Texas in that 12 cities study, but so they're talking about big cities like Houston and Dallas that participate, and then also you saw when it's talked about the 12 cities, those stars in the larger metro areas.
Mm-hmm.
That's where that data is coming from. So in Lubbock, I don't have any idea. I mean, I would have to really poll teachers. Did I answer your question?
Yes.
Okay.
For Lubbock to know, because we work with the state health department also, so we work with Freddie and them too, but you know, we go out and do the presentations and stuff for the schools. And Lubbock and most of the counties here, like in our 41 county that we cover, up to Perryton and down towards like Post, we go out and do maybe 3 to 4 schools in the 41 counties that will let us go in and talk about STDs. Everything else has to be abstinence only.
Right.
So that's the big problem around the Lubbock areas, because you can't go out and talk about STDs and sex and how to protect yourself. It all has to be about abstinence.
Right.
It's still abstinence.
It is.
I knew it was 7 years ago. But
Yeah, and like I said, you know, the analogy I gave with the battle gear, you know, that's you can't refer to it directly or whatever. But again, yeah, that's something that we need to. Yes.
I mean, I kind of understand what they're talking about. I graduated high school in 2010, and health class at that time wasn't a requirement. It was an elective. So you don't have to take it anymore, and therefore the little bit of education that we do get on it isn't even there, because they touch on it, I think, for maybe like 2 class periods is all we ever talk about it. So there's information here that I've never heard before. But is this state school system trying to make curriculum a little bit not as, you know, this is what's going to happen to you if you have sex, but just more of a educational, like, this is what is possible.
I really can't speak for the school system, and I couldn't speak to that. I hope that would, you know, that eventually it would be protecting yourself. But again, you know, that is the thing that we run into so often. And it's, you know, it's typically like in the college age kids, you know, that's where we can go in and talk and stuff like that.
Is there any way to trace back cases of known HIV to the schools that they attended and the programs that they were exposed to, whether it was abstinence or protected sex? Because me just growing up in the time that I did, it's become more of a protect yourself, and it seems like it's getting worse. And that may not have any correlation, but may have useful information.
Yeah, again, you know, I couldn't say specifically. You know, I wanted to. I'm delivering this material so that, you know, we can spread the word, that people become more aware. You know, one of the things that I noticed is HIV. When I came into this field, I went to nursing school in 1999, 2000, and then got out, and I took care of 1 or 2 HIV patients the whole time. And then so I'd all but forgotten about it, to be honest with you. Mm-hmm. And then got the opportunity to go into this field, and I was like, whoa, man, this is something that we certainly can't forget about, and especially if it's affecting this population. Mm-hmm. See, and you know, I want Dr. Barner to be able to chime in here, because we're.
Do you think if you tested more non-African Americans, that percentage would be higher? Because if they're testing twice as many African Americans as non-Hispanic and Anglo, I just wonder if that skews the numbers.
Well, I can't get this. I'm trying to get this thing to come on here, but just kind of gives a little information here about. Could I hit that? Anywho, yeah. So data here that I have that's just released in the overview of HIV in Texas, and this just came out about 2 days ago or so. I see here the statistical data says 1 in 112 black Texans are infected with HIV.
Wow.
And 1 in 524 white Texans, 1 in 536 Hispanic Texans, and the total number has now grown to 69,212. And typically, what experts at other conventions that I've gone to and have said is that a real good estimation for how much, what the HIV population is in your community is if you take 1% of the total population, because you're accounting for people that don't know their status, and it's only the ones that we do know that are in services that are accounted for.
I just want to make a comment, and maybe DSHS or Ricky or Lee, because I see them back there, will probably have more information. But you were saying whether or not it's the number and you're testing more African Americans. The numbers were already disproportionate before that happened. That's why it happened. That's why it started being targeted, because the numbers were disproportionate.
Yes.
The numbers for the rate of cases with HIV and AIDS were extremely high compared to the numbers in basis. And so that's why more funding was put into targeting those populations.
Targeting,
so yeah, you do see it, but that's what
Yes.
it is.
Well, even with targeted funding, the rate of why it's getting tested is still hand over fist more than African Americans, even pulling the bigger numbers.
Yes. Ricky Vaughn, he's one of the case managers with Project Champs. He's the local provider for services, brown and white services. Freddie's back here. You want to say anything, Freddie? That's Maria Salazar. She's a community planner on the team that I work for.
That's my coworker. We and Dalton all of us work together. I work with MH&R, and that's South Star here. And we run the HIV program. We work with the prostitutes, gangbangers, drug dealers, and I better get this right. September 1st, I've been with MH&R for 26 years. And when y'all look at those stats, we begin to talk about juveniles, and we talk about people in criminal justice. But we have to test with people just afraid to get tested. So some of the services out there, like Dalton said, we the first agency, prior to Lotus 7 years ago, called an Oral Quit. And so we can swap it in 20 minutes, you get your HIV test results back in 20 minutes. And the scary thing about that, people say, well, I want to wait 7 minutes. And we certified to draw blood, but still the process, people just don't want to get tested. The services out there, then they took, sex ed out of LISD school about 4 years ago. And so when Benny, my ex-supervisor was there, we were trying to get in the school, so we don't want to talk about it, abstinence, abstaining. Who's doing it? Even though we got to emphasize it, but who's practicing abstinence? We got to put it out there, but still, we offer condoms. We offer female condoms. So the services out there, just people just afraid to get tested. Yeah. And we tell people, we never met bad people, we always make bad choices.
And this is Freddie and Veronica. They're
my coworker right
They're
there.
actual boots on the ground out in the community doing the testing. And we're, like I said, we're the administrative agency. And we work with Project Champs to provide funding for brown and white grant services to provide care for HIV. So, anyone else have any questions? Let Dr. Bonner say a few words here.
How much time do I have left?
10 minutes.
10 minutes.
Yeah.
First, thank you so much.
Yes.
My background and my expertise, my knowledge is not in HIV/AIDS study. I was a teenager when I first heard about AIDS. And I remember thinking then in Southern California, where I was growing up, that was a disease of the other. Everybody know what I'm talking about? It strikes me that in 26, 27 years, that hasn't changed. And so the two questions that come to my mind as I hear this presentation, as I've done some of my own reading, and particularly as I look at adolescents, is one, why isn't what we are doing working? This video that was shown, I don't know who these gentlemen are, but they talk about these strategies that are in place and yet didn't mention very specific strategies, did they? And two, why doesn't the nation come together and recognize that HIV, AIDS, is not a disease of the other? I remember when I was a kid, I used to think that the disease was a disease of adults, or it was a disease of others. Those homosexuals out there, or those drug users, or something like that. And it strikes me that in all of these years, we really have failed as a nation to eliminate that stigma. And then of course, I look at this from an adolescent perspective. Why are they having sex? There's a lot of reasons for that. And I noticed in your slides, the concept or the term, the idea of family kept cropping up. And this is where then I have done a lot of work. What's going on in our families? Education is certainly necessary, but is education taking place where it needs to take place? Or are we trying to put a Band-Aid on a compound fracture? I confess to you, I have more questions than I do have answers. The area of research that I'm most interested in, that I've spent a lot of time in, is looking at the extension of adolescence. Junior high, really, that age group, the lower age range hasn't changed too much, but the mid-adolescent, the high school age student has changed quite a bit. When I graduated high school in 1990, I very much knew who I was. I had developed a core self. I could operate out of my core self. I had a core identity, and I made choices out of that identity. Students graduating high school now do not have a core identity by and large. Right now they're functioning out of multiple selves. And what that means is that in any given environment or system in which they find themselves, they will adopt or adapt a persona in order to feel safe and secure in that environment. And so what does this mean for like educators or like here at LCU? In an education system, like in a high school, you might see Johnny in math and he be one way. You might see Johnny in English, he be a completely different person. And then you see Johnny in another environment and he be a completely different person. And the way I kind of image this, the way I look at this, picture an adolescent as an octagon. And each side of the octagon being various windows. And when you look through the windows of an adolescent, you see something very different than you do an adult. You look through the windows of an adult, the roles of an adult, you see one candle burning brightly in the center because the adult has figured out who they are. That used to be true upon graduation from high school. I think it is that understanding, the development of abstract thought, the development of a core identity, individuation is dropping. And so even now, okay, so what does that mean? Well, it means a lot of things. One of them has to do with high-risk behavior. As an adult, when we assess something that is high risk, we tend to look at the outcome, the end result, right? Well, I would suggest to you that developmentally, an adolescent no longer has the ability to evaluate what long-term consequences are. And so they will proceed to have unsafe sex. They will proceed to do all of these different things that this audience knows all too well. Because they don't have the ability, I would argue, to determine in the middle of the action or before the action, particularly when it's combined with alcohol, what the long-term consequences are going to be. Okay. Second, many, many years ago, I remember sitting in my office. I come from a youth ministry background, so you need to know that. I'm a Bible professor here on campus. A mother and her 5th grade daughter came into my office and wanted my help. What can I do for you? And the 5th grader began to tell me this. In my school of 4th, 5th, and 6th graders, the kids are all practicing oral sex. And it's not just one way, it's both ways. And not only that, they're paying each other. And this mother and her 5th grade daughter wanted me to help them address the situation. And it was then I began to realize that we're rapidly moving into a culture that has really opened Pandora's box. Now, it's always been there, but now it's becoming widespread. I mean, no matter where you stand on this, the very last inauguration, which was just recently, the President of the United States came out in vocal support of same-sex marriage. I believe that President Obama has always felt that that was okay. But 4 years ago in his inauguration, he didn't say that. In 4 years, folks, in 4 years, we have gone from a nation that was kind of hush-hush, a growing awareness, to where it's almost acceptable. Except, ironically, in the South, where a lot of these numbers show up real high. And so we have students that where adolescence is extending, and a lot of the numbers that he showed, I would include the 20 to 24 age in adolescence. That's how I look at it. Adolescence is extending, it's beginning earlier, and it's lasting longer. The cognitive ability of our students is dropping. It's taking longer for them to individuate. Certainly this has got to play a role into it. But here's what I've noticed almost across the board. Almost across the board. And I'm very much a practitioner like many of you are. I work with families. I'm a preacher in a local church. I work with kids still. My background is working with youth and families. Here's what I found. Almost across the board, when a student comes from a strong home, they individuate before they leave high school. What is a strong home? A two-parent home. Today after chapel, I had a 20-year-old female rush up to me, caught me off guard, interrupted a conversation I was having. But I've spent some time with her on Facebook, through email, and in person. She's a teenage mother. She tells me today that, and it turns out this teenage mother is addicted to sex. And it bothers her that she seeks solace, satisfaction, and many other things through sexual relationships with men. And I don't know how many relationships she's had. She runs up to me today to tell me that she thinks she's broken that cycle. And I asked, okay, what began the cycle? What began the cycle was a father who told her that you need to be a stripper so I can come to the club and watch you dance. Here's the reality. And I think all of us know this, although we may not be willing to admit it. Families are falling apart, generally speaking. And the more we see that trend, I think we're going to see this trend increase. And so when I speak of, okay, how do you prevent this, which is one of the things I'm curious about, how do we slow this down? I'm not looking at just addressing those who have HIV. I want to be proactive. I want to get on the front end of this. And if that means some of the education that you guys are talking about, being prepared for battle, I understand that metaphor. I was in the Army 6 years. But I've got to admit, I come from a little bit different perspective. I don't know what this translates, how this translates in the nursing community, in the medical field. I know in my background, it means investing in families. It means stepping into families and effectively loving them well, providing them resources. I'm aware of the zip code on the east side. I'm a part of a team that does a lot of ministry over there. I'm aware of some of those numbers and some of the tragic stories that come out of that side of Lubbock. But I think I'm convinced more than ever the direction our culture is going. If we as a culture don't effectively step into the lives of families, I don't care how much money we get on the federal level. We may stump this for a little bit. Teen pregnancy, holding steady, despite education and everything, despite all of the science out there, right? Divorces, it doesn't matter if you're Christian or not Christian, holding steady about 45, 50% for years now. I think perhaps while we need to be educated with all of the different realities to be exposed to, until I was asked to respond, I hadn't even thought about it. It's not necessarily in my world. I deal with kids, you know, having sex and doing drugs and alcohol, kids who are abused, which, by the way, are all precursors to a lot of this stuff that's going on. So, I had a lot more to say, but I know time's short. I got to tell you, my heart is warmed by such a full room of people who are so very concerned about the needs and realities of adolescence. It is the health and the spiritual and physical health of adolescence is near and dear to my heart. And so while I'm not in full-time youth ministry anymore, I prepare students to step effectively into the lives of youth and their families. So, thank you. Thank you so much. out in the